Welcome to HealthWatch, presented by Novant Health. I'm your host, June Baker. This show is all about exploring health topics that matter to you and your family. We here at Novant Health appreciate the opportunity to introduce you to local physicians and healthcare professionals who serve as our health experts. Today, our guests include Dr. Dawn Young, Dr. David Schmitz, and Dr. Michael Stoiko. So please stay tuned to learn more on HealthWatch. Let's kick things off today with one of our newest providers, Dr. Dawn Young. And she's with Oceanside Family Medicine here in Leland. How are you today, Dawn?
Doing well, thank you.
Thank you so much for coming today. I'm so excited to meet you and to spend time with you, and I know our viewers are going to love this. So you're new to the area.
I am.
So let's kind of start with the basics. Tell me a little bit about yourself.
Well, I've been in family medicine for 30 years now.
Really?
I have spent all of my career up in northern Indiana, in South Bend, where I've practiced family medicine there. I went to medical school in Kirksville, Missouri, and then spent the rest of the 2 years of medical school after the actual school part of it, traveling around mostly Midwest, a little Southeast, doing student rotations.
Right.
And then I did my residency in South Bend, Indiana as well.
Are you excited to be here on the coast?
Oh, absolutely. Yeah, I moved here mainly because of weather.
Really?
South Bend, Indiana can be about 6 months of cold and snowy weather. So it was refreshing to come into an area where I knew the worst I was going to get was maybe 40 degrees and no snow.
Yeah. Had you been to the area before?
I had. My sister actually moved down here a year ago, and so we visited actually on the 4th of July weekend last year, and right when the tropical storm Colin was hitting, but that did not deter me to come back here. So yeah, no, we knew once we got here this would be the place to move.
Well, that's awesome. We're glad you're here.
Thank you.
And Leland is such a growing community, and I know the healthcare, we really need more healthcare in that area.
Absolutely.
So I'm sure you're busy already.
I am.
So you say you've been a primary care physician for 30 years.
30 years.
So what made you decide to concentrate on family medicine?
Well, I think when you start doing student rotations, you try to find things. I initially thought I would be a pediatrician, but I did 1 month of pediatrics and decided I did not want to do that every single day. So I like the span of, I always say 0 to infinity. So, and I had a concentrated older adult population in South Bend, but here I'll be getting back into pediatrics a little bit more. So.
Oh, that's nice. Yeah, that practice does see quite a few pediatric
children.
patients. Yeah.
So
that area has a lot of young families with lots of children.
Yeah, that's what I've noticed already on my schedules.
Yeah, that's pretty cool. So let's talk more about annual wellness visits, and some people call them yearly checkup. I call it a yearly checkup. So, and a lot of people I hear, they just don't prioritize that.
No.
What are your feelings about that? Is that a bad thing?
Not prioritizing it, yeah, I think it is a bad thing. I think that doing a well adult physical exam once a year is a good thing. It gives people a chance to find out something that could be lurking there that they wouldn't know about unless they came in and perhaps was an incidental finding on a test. And so getting screening mammograms and colonoscopies and blood work, all of that's really important just to kind of get a level basis of where you're at.
I always refer to my primary care physician as like the leader. He looks at, or she, they look at everything, all the places you've been and all the doctors and all the medications, and he's kind of my maestro of the orchestra.
And I really do believe that. I think that a good medical team starts with somebody in the center, and for the most part, the family practice doctor is that person coordinating every bit of the care.
Yeah. Well, tell me what your annual wellness looks like. What all would you do during your a patient's annual wellness visit?
Well, it depends on the sex of the person because there are different testing. But for the most part, annual wellness visit would include going through a history and seeing if there's been any changes with anything, including medications, procedures, etc. And then also focusing in on any testing that they have not had, vaccines that could be updated, blood work to be done, do they need any screening, x-rays or that sort of thing, and then getting it all coordinated, and then making sure there's nothing acute along the way, but generally the chronic stuff.
Yeah. I'm sure family history comes into play there.
Absolutely.
So what about folks who don't know a lot about their family history? Maybe they were adopted or something like that. And then I hear where folks say, well, I'm scheduled with a new primary care, but they want all my old records. Right. Is that absolutely necessary?
It's not absolutely necessary. I think it's important if we can get that, just because you have base or what do I want to say, like the old results to compare to. Frequently we'll say, you know, there's a new change on your mammogram. I wonder if the old mammogram had this on there and it maybe wasn't seen, or it's a new finding. So getting new findings, it's always nice to have something to look back on. So it's good. It's not absolutely necessary, but it could be a very needed thing. Yeah.
So now we're into summer, and a lot of people are exercising and dieting and working on, you know, getting in better shape. So does that help when they come in for a physical exam? Do you talk about that, or do you like lay out a plan for?
Well, I think it's always necessary to talk about a good diet and exercise, and some people need it more than others, and some people just aren't exercising, and so I always make it a point to encourage proper diet or a healthy diet and exercise. It doesn't have to be every single day, but I think that it's important as people stay active. I'll have to say I used to see a lot of 80 and 90-year-olds, and all of those patients, they were active every single day, and I think that's what, you know, joints like to move. So definitely.
Yeah, they do. Even when I get up in the morning, my knee kills me, but as soon as I start walking around, and you know, it feels so much better.
I always say we're like the Tin Man. Once we get a little bit of lubrication, we feel pretty good after that. So
are you taking new patients?
Yes, absolutely.
Yeah. So how do we go about making an appointment with you?
Well, you can call the office at Oceanside Leland, and I am not familiar enough to know if there's a call center, but I think either direction would get you to a new patient appointment with me.
Well, that's great information, and it's been so nice to get to know you.
Thank you.
I think you're so easy to talk to. I think your patients are going to love you.
I hope so.
Oh, they will. I know they will. So thank you so much for being here today. I hope you'll come back, and we'll find a specific topic to talk about.
All right. Thank you so much.
You're welcome. Please welcome our next guest, Dr. David Schmitz, and he's with Novant Health, Oceanside Family Medicine, right here in Bolivia. Welcome back to the show today.
Thank you.
You're always such a great guest. Thank you for giving up time today.
My pleasure.
Great. Well, June is National Men's Health Month, and so we're going to sort of focus on that.
Sure.
So tell me why it's important for men to play an active role in their health care.
Well, men are oftentimes seen as the providers or the stalwarts of the family. So they're there protecting others and making sure others get their care, sometimes at the lack of their own. So to ensure that they stay healthy, it's important that they be seen at least once a year for a regular annual physical assessment with lab work to make sure that they're healthy and to make sure they're not falling down any health problems that may have run in future or previous generations.
I know an annual wellness visit probably looks different for every patient and every condition and so on and so forth. But what are some of the things that a male patient might expect to experience in a wellness visit in your office?
Wellness visits are actually pretty standard. They'll be blood lab work ordered about a week before. The patient comes in for their clinic visit where they'll come in, we'll talk to them, we'll ask them if there's any new concerns, any new issues that they want to address. We'll try to work through either further investigation or what could be causing those. Then we'll start talking about the results from the lab work that just came in, if there's any new trends we need to address there that may have changed. Brief physical exam, usually assessment of, head, eyes, ears, nose, throat, heart, lungs, and then their kind of warranties renewed and they're set on their way.
I'm curious, are wellness visits different for like a Medicare patient versus a younger patient not on Medicare?
Not typically.
Okay. Little more paperwork, maybe?
Medicare visits have a giant packet of questions that Medicare really likes to know. We don't actually do anything with that. We just pass the information along. Otherwise, it's pretty much the same where it's blood work, it's physicals, and then, back to the regularly scheduled life.
Yeah. Let's talk about blood pressure.
Sure.
I know we have to watch our blood pressure. So if we're taking it at home, a male patient, how often should we do that?
Well, it depends.
Okay.
If they have a diagnosis of hypertension, probably once, twice a week.
Oh, okay.
If you're on blood pressure medication and you feel abnormal, it's always good to come in, rest, and take your blood pressure to see if there's a change. That way you can notify the doctor, and we may need to adjust medications to control it better when you're active. If there is no diagnosis of hypertension, home blood pressure monitoring is always better than the models you see at Walmart or CVS, because those are never calibrated. But checking them, I don't know, once or twice a month if you feel anything abnormal, just to kind of get a baseline of it is. But it's always, come in, rest for 15 minutes, then start it so that you're not walking right in and taking it because we know it's going to be high.
Yeah. Right. And do white coats tend to raise blood pressure, or is that a fallacy?
So actually, that's a good one. The American Heart Association a couple years ago said that home blood pressure monitoring is actually much more accurate and reliable than a false office-based situation where patients tend to be a little more apprehensive that they're going to get bad news. So they're always a little on edge. They come in, they wait, then we have them stand up, walk over here, walk over there, answer all these questions, quick, take this, and they don't have time to relax into it. So they actually do recommend more blood pressure monitoring at home and bringing that log in for us to review.
That's a good idea. Yeah. That's good to know. I'm usually late, so I run up the steps, I run in, and my blood pressure is like sky high.
Exactly. False elevation.
Yeah. How about when you run all this blood work, like urine and blood, what are you looking for?
It's a good way to get us a baseline of what enzymes are active for different organs in the body.
Okay.
Instead of running full body CTs, which are never approved or anything like that, the blood work gives us a good analysis as are organs working appropriately, filtering and maintaining different enzymes and electrolytes and activities in the body to give us a general idea of how well they're still functioning.
Okay, let's move on to prostate screening. I think there are some new guidelines out there. Can you remind us what those are?
Well, that is actually, I was just having a conversation with our urology department. There's a bunch of societies out there that have differing values. Our office uses the ones provided by Sloan Kettering, which bases prostate examination starting at age 45 through age 70. And then delineates, based upon the PSA result, how often they get tested after that and when to elevate from just a blood sample to an actual urological visit where they may want to do an ultrasound or a digital rectal or even sampling.
So you probably talk about that process with your patients.
Anybody who has a family history of prostate cancer or ends up talking about issues with urination, too often not feeling fully voided, getting up multiple times at night, run the PSA, see what it results at, and then based upon those results, either monitor or elevate examination from there.
Oh, good to know. So the next thing on my list is colonoscopies, and I know that's for some people that's a dreaded a thing, but to me with the new preps and stuff, it's really not all that bad.
Yeah.
How important are they?
Well, a colonoscopy is always easier to manage than colon cancer.
Oh yeah.
So, with the easier preps, it doesn't really take as much out of the individual, especially when we're talking about elder population that are still receiving them. It can be, with multiple diseases, it can be pretty intolerant. If there's no history of cancer, there's never been a polyp, home testing using the Cologuard kit is always appropriate, yeah. If there's ever been a family history or an abnormal Cologuard result or a polyp, then follow up with colonoscopy with our gastroenterology department's appropriate. But again, that's also based on, have they ever found one, to determine how often they get it, and what type of polyp was found. Since there's multiple types that can be found, either regular, not mild dysplasia versus more significant ones, to determine, are you on a 1 year, a 3 year, a 5 year, or a 10-year plan?
They typically remove polyps during
at the time. If they find them, they will always remove them, depending on the severity, but I don't think I've ever heard of one leaving one behind and having to go back in later for it. And then they'll send it off for testing to see what it is and if they need to advance for other type of assessments.
And again, you can have them every year or every 3 years, depending on what they find.
Absolutely.
Is that correct?
Yep.
And then after, 75?
75 is when they typically end.
Unless you have
Right. Unless there's a significant abnormality or there's just so many polyps every time, they usually can get them pushed out to age 80. And then after that, of course, if specialty recommends it, it can always be discussed with insurance for coverage. Yeah.
Wow. I know that mental health has been in the news a lot lately. Do family physicians typically broach that subject?
Absolutely. We are the gatekeepers. So we get all the comments and all the concerns. So if anybody has any issues for anxiety, mental health, they absolutely need to bring it up with their family doctor so we can address it and either start treating it or get them the treatment they need.
Any other health and wellness tips for us today?
Just making sure you come in and get your regular exams at least yearly so that we can catch any problems early, because even if it's a little bit right now, you don't want to wait till it gets big and is much more hard to treat then.
You have 3 providers in your office. Are you taking new patients?
Absolutely we are. We're always taking new patients. We can always get people in. Just call the front office and give us all your information and we'll get back to you.
Great. Well, thank you so much for sharing your expertise with us today. We love having you on the show. You're a great guest.
My pleasure. Thanks for having me.
We'll see you soon.
All right.
Please welcome our next guest, Dr. Michael Stoyko, who's a pediatric intensivist at Novant Health, New Hanover Regional Medical Center. Thank you so much for coming today, Dr. Stoyko. I'm so excited to hear about the Children's Hospital in Wilmington. I know it's been there a while, but we're going to reinvent it, sort of.
Great.
So tell me a little bit about your background.
Well, I've been doing pediatric critical care now for a little over 37 years.
Really?
And between me and my 2 partners, Dr. Paulson and Dr. Pod, we've got about 80 years of experience.
Wow.
But I trained actually in pediatrics initially, and then did training in anesthesia and pediatric intensive care and neonatal intensive care in Boston back in the 80s.
Yeah.
And came here about 10 years ago to help build the Children's Hospital here.
So you treat all those little tiny little babies that are born and end up in NICU and
When they get bigger.
take care.
If they're there, when they're that small, they're in the neonatal intensive care unit. Once they've left that unit, or if they get sick when they're older, really up to age 18,
Oh, really?
we'll take care of them.
Oh, good to know. How did your upbringing and the history in the medical field, does that help you to connect with the children that you treat?
It does. To give credit to my mother was a second grade teacher,
Yeah.
and was one of these people that just could not stop to talk to a child if she made eye contact with them. Was always loved children, loved babies, and I inherited that from her. So when I'm taking care of children, I connect with them not as a physician, but just as another human being who happens to be the doctor taking care of them.
How sweet. How sweet. Yeah, I love when we see kids in the hospital. It's very endearing to me. I understand that you don't wear a white coat like most physicians. Is that the case?
That is true. I actually stopped wearing them in 1989.
Really?
Because I saw them as they're more, it used to be a symbol that you were clean. You weren't all covered in blood or something.
Right.
So you're coming in and look, you've got this nice shiny white coat on. But children don't recognize that meaning, and they don't recognize the purpose. They just see it as strange and different, and you don't look like a person to them. And it's scary for them.
It is kind of scary.
So I stopped wearing the coat and would come in, and they kind of look at you like, I'm not sure what you are, but I might give you a chance.
Kids are pretty smart. They know who they can trust, and that white coat is kind of scary, even for adults.
It is.
Yeah. So I really want to concentrate on the Children's Hospital. So tell me more about the hospital, and what would you like our community to know about it?
I would say most importantly is it is an amazing place. We've got physicians that are second to none. We've got now a number of subspecialists, and that number is growing both in depth and width. We've become associated now with UNC Children's, so the doctors are technically UNC Children's Wilmington.
Okay.
So I'm on the faculty, and all the other physicians are on the faculty at the University of North Carolina. We have a group of 3 peds intensivists and 6 inpatient hospitalists that take care of sick children. We have a large cadre of neonatal intensive care doctors and nurse practitioners, and the care that we give, I think, is really excellent. And it's very personalized, much more so than it is at a large academic type institution. And it's growing leaps and bounds. Just in the past few years, last year and a half or so, we've hired about another half a dozen subspecialists, and we're going to keep growing.
Now I know that when you're looking at the hospital, on the left you have the Betty Cameron Women's and Children's Institute, I believe it's called. So all of the pediatric services are encased in that building?
All of the inpatient services and some of the clinic. And then there's also out on the way to Wrightsville Beach.
Oh yeah.
There's the Nunnally Clinic out there.
Nunnally, yeah.
And it's a gorgeous building. It's a really, really lovely facility, and a lot of the pediatric subspecialists work out there and see patients there.
How many beds do you have in the Children's Hospital?
Well, we have technically about 25 inpatient beds.
Really?
For children. We have a 7-bed ICU that is sometimes 8, sometimes 9, sometimes 14.
Whatever it takes.
We adjust depending on the census. And the neonatal intensive care unit is technically 45, but at times we'll go up to 48 or 50.
I did not realize it was that large.
We're talking about almost 100 beds, yes.
Wow. I had no idea. And I bet you a lot of people in the community don't know that.
I suspect you're right. unless you've had the experience of having somebody you love there, you don't really know what's going on most of the time.
So really there's no need for patients to travel outside their communities here.
Rarely.
To get this kind of care.
For example, we don't do pediatric heart surgery here.
Right.
But we do take care of children with heart disease.
Right.
But if they need surgery, then we would send them elsewhere for that surgery. If you need a bone marrow transplant, for example, that's a very highly technical area that requires tremendous resources to support it, and that's not something that would make sense for us to have here at this time.
I know you're always trying to grow pediatrics services because the influx of people and the community is growing leaps and bounds. So I know you're always trying to grow those services. What are some of the things you think that, what are you doing now to enhance the care that you provide, and what do you see in the future?
Well, right now we just expanded up to our 3rd pediatric cardiologist, our 3rd pediatric gastroenterologist, GI doctor. We're looking to expand neurology. We just hired a 2nd peds neurologist. We have a 3rd one that helps out, so we really have 3 now. And we're looking in other areas to maybe expand there too. And at some point we're going to have to expand inpatient services because we just keep getting busier and busier.
Yeah, and that's truth.
Yeah.
And we all see that. We see that here locally at this community hospital. There's never enough beds. And and it's quite a feat to get extra beds. It's hard to get those beds given the states, some of the state guidelines and what have you.
The certificate of need is challenging.
Yeah, it's very challenging. I hear it's probably going away in a couple of years given the Medicaid expansion.
That is the plan.
And speaking of Medicaid, do you see a lot of Medicaid patients? Is that part of, does that get covered in your?
Yes. All the kids in North Carolina are eligible to be on Medicaid if they don't have the family resources to pay for ACA care or whatever,
right.
Obamacare. So most of the children that we care for, the majority of them have Medicaid. And if they don't, when we first meet them, we try to get them signed up for it.
And you can help with that, help with that process of.
Yeah, we have social work and case management that will help us get those kids enrolled. So we rarely have we don't have children that are uninsured in that sense.
Right, right. And everybody gets treated the same.
Yeah. Oh yes.
It doesn't matter. Whoever walks through the door.
No, I now have grandchildren. I had 3 children. Now I have 2 grandchildren, and I can honestly say I attempt to, and all the people I work with attempt to take care of the person the way you'd want your child or grandchild taken care of.
Yeah.
And that's important.
It is very important. Do you have an emergency department just for children?
We are in the process of separating out an area specifically for that with people who will be trained just in pediatrics. And the plan for that, probably won't be fully developed for about 2 more years. But right now we've started that process of separating that out.
Okay. And that wouldn't just be for like critical care patients. That would be for bee stings and all sorts of things, right? That a child may encounter.
Yeah, if a child has a more serious condition when they come in the door, they will actually call me or one of my partners, and we'll come down and work with the emergency room physician to help stabilize them and so on.
So that's what happens now. But in the future, you foresee a specific emergency department for
fellowship-trained pediatric ER physicians.
That would be so great. You know, your kid falls down and hits their head and they have this big goose egg, and it would be great to have just a children's ER that you could walk into and receive that top-notch care. So
that has been our goal, and it is happening now.
So I want you to come back, but it sounds like there's all kinds of things on the horizon. I would love to have you back on the show so we can go through some of these things and just keep in touch about what's going on at that children's hospital.
I would love that. Thank you.
And I'm excited to go out in the community and talk about this now that I know more about it. It's great. So thank you so much for coming today. I would love for you to come back, and I'll get it on your calendar.
Thank you.
How's that? Thanks again for being here. Thank you for joining us today for HealthWatch. If you'd like more information about services provided at Novant Health, or if you're looking for a new physician, please visit our website at novanthealth.org. Please join us next time on HealthWatch.